So today we will proceed on our journey to gastroenterology examination. Today we will proceed to our journey to the gastroenterology examination. My plan is that after doing some progress to some extent, we will take case demonstration, bedside, at the bedside. But before going to the bedside, you should have this knowledge. That is why I am taking the theory classes, and after that, getting some amount of knowledge, full knowledge is not possible, not for anybody. So after gaining some knowledge, we will proceed to practical examination of the patient in the bedside. So our next class is inspection, palpation, percussion, like that, and I may take some class on liver after that. If I get case in between, then we will go to straightway to the bedside for case discussion on liver, and if we according to the availability of the case, we will discuss according to that. But before that, you should go through this, and also you read in the in your home what we have studied till date, because all these things will be discussed in the bedside. In the bedside, I may ask questions and you should answer that, what you have written till now. Only hearing and gathering will not work. So this part I have done previously. This is a new slide. Now examination of the abdomen. We have done general surveys. General survey and other important upper GI tract examinations we have studied. Now we are coming to the true lower tract or true abdomen. After examining upper GI tract, we have already discussed in our first class the mouth and everything. Then we will come to the abdomen. But remember these things. It is important in your for clinical purpose that abdomen is subdivided into 9 regions. You know that. 2 horizontal and 2 vertical lines. The upper section of is subdivided into right and left hypochondrium. Yes, thank you. Right and left hypochondrium and epigastrium. Epigastrium in the middle, and in the 2 sides there are right hypochondrium and left hypochondrium. And middle sections is umbilical, right lumbar and left lumbar. And below that, lower section is in the middle suprapubic region, hypogastrium, and there is true iliac fossa, right and left iliac fossa. So two straight lines, the lines are not mentioned here. You know the lines. You know the lines, no? How the lines are drawn. You know that at the lower, the horizontal 2 lines are drawn. The upper horizontal line is drawn at the lowest point of the chest. The ribs ended at the lowest point, the rib cage, at the lowest point of the rib cage. You take the point in the right and also take a point on the left. This will be your upper horizontal line. That is a connection of the 2 points at the lowest point of the chest, rib cage. That is upper horizontal line, and the lower horizontal line is at the highest point of the iliac crest. Highest point of the iliac crest. It is laterally. The highest point of the iliac. Go to the follow the iliac crest, and the highest point will be the point. Take 2 points, 2 sides, and the horizontal line drawn to the highest point of the iliac crest. That will be the lower horizontal line. The upper horizontal line I have already mentioned. That is the lower point of the chest. These 2 horizontal lines, and 2 vertical lines are just mediunguinal lines. Just mediunguinal point. Draw a straight line along the 2 mediunguinal point. That is 2 longitudinal lines and 2 horizontal lines. This will divide the abdomen into 9 compartments. Now we will discuss which compartment contains which organs. Right hypochondrium, you all know that it contains the right lobe of the liver. And what are the other contents? Is gallbladder, important. And there is hepatic flexure of the colon. also called right flexor. Upper part of the right kidney also it is a part of the content of the right hypochondrium and right suprarenal gland. These all makes the organs in the right hypochondrium. Similarly, in the epigastrium, we have pylorus of the stomach, and naturally the liver from right goes to the left, so it is a part of the liver will be there. Pancreas is of course there, aorta and duodenum. These all are the contents of the epigastrium. Then left hypochondrium, the spleen, the tail of the pancreas, then it is a left flexor of the left colonic flexor, or this is also called splenic flexor of the colon, upper part of the left kidney and left suprarenal gland and part of the stomach. Now right lumbar region, it contains the right lumbar, the right kidney and the ascending colon and part of the duodenum and jejunum. These are the contents of the 4 compartment. 5th compartment, umbilical region. Umbilical region contains, main content is omentum, and it also contains transverse colon, parts of the jejunum and ileum. Left lumbar region contents are the lower part of the left kidney, the descending colon and the part of the jejunum and ileum. Jejunum and ileum is everywhere, you know, the whole abdomen is contained in jejunum and ileum. It is repeatedly mentioned that, that's why. The right iliac fossa, you know, the lower end of the ileum, it is a terminal ileum. It's very important to know that the various diseases will come across in the terminal ileum, where the ileum ileus joins with the cecum. That is terminal ileum. The cecum and the appendix in the right iliac fossa, right ureter, right ovary in female, and right spermatic cord in male. Hypogastrium, content of the hypogastrium are, this is the lower part, the urinary bladder, you know, and the enlarged and gravid uterus. If the uterus is gravid, it becomes a part of the hypogastrium and the coils of the ileum. Left iliac fossa, the sigmoid colon, the left ureter, the left ovary in female and the left spermatic cord in male. This completes the contents of the 9 compartments of the abdomen. In hiatus hernia, a portion of the stomach enters into the thoracic cavity. You know, in hiatus hernia, there is a hernia, there is a inner hernia through the diaphragmatic orifice. The esophageal stomach junction, esophageal and stomach junction, esophageogastric junctions. It is drawn, it is going to go to upward, and some part of the stomach may be the content of chest. That is an abnormal situation where hiatus hernia, portion of the stomach. But what we see in inspection in abdomen? What we see in inspection? Stand at the right side of the patient and look at the abdomen well exposed and also in sufficient light. You observe the abdomen. What you want to see? What is the contour? Very important contour of the abdomen. What is the normal contour? It is scaphoid. Normal. What is the normal contour? Scaphoid or is the normal contour? See the way normal contour is there, but see whether it is scaphoid or it is distended. Whether the abdomen is normal contour, you know the abdomen, how it looks like. You say it is a normal contour is normal, or if it is distended, this umbilicus is everted. What is the signs of distension? Umbilicus is everted, and the skin looks shiny. Then it is distended, or it may be opposite. It may be scaphoid. So use this term: is normal, it is scaphoid, or it is distended. Hey, don't gossip. Hey, listen, don't gossip. কি আলোচনা এর থেকে ইম্পর্টেন্ট আলোচনা বল তাহলে আমরা শুনি যে maybe important in this. So that is so distended. How the distended abdomen is explained? It is the flanks are full. Flanks, abdominal flanks, you know, the side of the abdomen. It is curved. It is a curvature is there, no, in the side of the abdomen. But if it is full, then we can call it as a distended. Flanks are full, It is free, if there is free fluid. Other causes are free fluid, all ascites. Free fluid in the abdomen is called ascites. So, inspection in ascitic case, if you just told to inspection, do inspection, then the abdomen is distended, and always mention the flanks are full. Always mention this term, flanks are full. Examiner wants to listen to these terms, flanks are full. Other causes are intra-abdominal tumors. Any intra-abdominal tumors will distend the abdomen, full bladder, intestinal obstruction, and obesity. These all are the other causes of abdominal distended abdomen. But for our examination purpose, two very important cause. One is free fluid in the ascites, or there is intra-abdominal tumor like ovarian cyst. A huge ovarian cyst may distend the abdomen, or there is a huge any tumor inside can distend the abdomen, or there is free fluid. Now, thereafter, after this contour of the abdomen, you go to the condition of the skin. You may see white striae in the skin. White striae, maybe if it is there, you must mention. I can see the white striae in the abdomen. What is the cause of those white striae? You have all experience. Experience is seeing in somebody, or either in your abdomen or some others, there are some white striae. What are the conditions? Main condition is losing weight. Main condition is losing weight. Suppose a patient, obese patient, lose weight very rapidly, then there will be white striae in the abdomen. But there are some other important causes are there, like sudden loss of weight, pregnancy definitely, after paracentesis of the abdomen. There was a huge ascites, you have done the ascitic fluid drawn, you have drawn it, drawn up the ascitic fluid, then the pathology is same, distended abdomen becomes very less distended very rapidly. So, there is white striae appears on the skin. So, these are the causes. And another is pigmentation at the crease after paracentesis. And this white striae also are the favorite site for pigmentation. If there is any cause, if there is a cause of hyperpigmentation, we have discussed in our previous class. What are the causes of hyperpigmentation? And these white striae are very favorite site for hyperpigmentation. Look for it, whether there is any hyperpigmentation. This is the white striae, but in the Cushing syndromes also we get some striae like this, very important. This is a purple color, but we get striae in the abdomen in Cushing syndrome. It is usually not white color, very difficult to detect white and purple in a dark skin patient. But if you have a very fair skin patient, you can detect it is white or very purple, or at least in a Cushing syndrome, if there is case, you mention that there is a striae. Then you go for inspection, you go for umbilicus. See, the umbilicus is inverted or it is everted. There are everted, I have already mentioned that everted umbilicus indicates there is increased intra-abdominal pressure. Can it be due to fluid or maybe tumor, whatever it may be. In inverted umbilicus means there is less abdominal pressure, so the umbilicus is inverted. Sometimes it is inverted normally. In a obese patient, you see the umbilicus is inside, very much inside, in obese patients. So, obese is inverted maybe normally in a very obese patient. Now, this bluish discoloration of the umbilicus is also called Cullen sign. It is seen in acute pancreatitis. Very important, remember these terms. In acute pancreatitis, there is bluish discoloration of the umbilicus. It is called Cullen sign. Another sign is also called Gray Turner sign. It is a greenish discoloration in the loins, not in the umbilicus, in the loins. This is also found in intra-abdominal infection and sepsis. Bolo. Gray Turner, Gray Turner sir green discoloration, the blue na. It is not in umbilicus. Actually, it is an iliac fossa. You see that it is in the loins. Loins means in the iliac fossa, almost not in the umbilicus. But signs are important because these are the signs of acute pancreatitis. And or not only in acute pancreatitis, in any intra-abdominal sepsis. Not only pancreatitis, intra-abdominal sepsis, you can see the Cullen sign and the Great Turner sign. Or you may see some sinuses. What are the causes? Meckel's diverticulum. The Meckel's, the spelling is not properly written. Meckel's, M-A-C-K-E-L. Meckel's diverticulum and persistent urachus. Urachus, there is a, from birth there is a urachus, is a structure. If there is a abnormality, if it is abnormally persistent, then it may be discharging. And discharging sinus, persistent discharging sinus at the umbilicus. It is a persistent of the urachus. It is a structure from the birth which should be closed after birth, but if it is persist after birth, then it is called persistent urachus, or there is it may cause a discharging sinus at the umbilicus. You can see it there. Distended veins, very important. Distended veins, we know it is found in portal hypertension, in cirrhosis of liver. We see distended vein around the umbilicus. It is called caput medusae. Caput medusae, there is a Greek দেবী যার মাথাতে একটা মুকুট পড়া আছে, মাথা থেকে প্রচুর সাপ বেরোচ্ছে, তার ছবিটা এরকম, ক্যাপুট মেডুসি, হ্যাঁ হ্যাঁ মেডুসি সেরকম দেখতে লাগে। আমাদের পোর্টাল হাইপারটেনশনে দেয়ার ইজ, কারণ পোর্টাল হাইপারটেনশন দেয়ার ইজ পোর্টোসিস্টেমিক অ্যানাস্টোমোসিস ইন সাম প্লেসেস। umbilicus is a site for portosystemic anastomosis, as rectosigmoid junction is a site for portosystemic anastomosis. Esophagogastric junctions, the site for portosystemic anastomosis. So, when there is portal hypertension, the portosystemic anastomosis will get dilated, because of normally we do not see it, but if there is portal hypertension, these anastomosis get dilated and we can see visible, it is visible. Similar, the esophagogastric junction is not visible, but we can see it by endoscopy, there is varix. In the rectosigmoid junctions, it is visible by sigmoidoscopy. Sometimes we can feel it also, parectal examinations. There is distended veins. Similar veins are seen in the umbilicus. Due to portal hypertension, this is called caput medusae, is a signs of portal hypertension. Umbilicus may be red, raw and angry looking umbilicus. Causes are chronic infective granuloma. This is important. Some patients has a habit of scratching the umbilicus continuously. Sometimes they have a chronic infective granuloma, and you know the umbilicus is the least vascular organ in the body. It is not vascularized very well, so it is very difficult to heal. If the area is not vascularized well, very difficult to heal. And even if you go give some medicine, the medicine is also very difficult to reach there. That's why this so umbilicus is a site for infections, and it can cause chronic infective granuloma. Then umbilical adenoma, or it is also called raspberry tumor. There is adenoma in the umbilicus, it is also called raspberry tumor. Umbilicus may be the site of secondary deposit of several cancers, particularly stomach, ovary and breast. This is a site for secondary deposit, and that umbilicus may look very angry looking, ugly looking, or discharging also. And endometriosis is a part of the gynae, but is one of the cause that endometriosis, there may be deposit in the umbilicus also, and it may bleed periodically. Now, movement of the abdomen. After the inspection, now ask the patient, see the normal movement of the abdomen. Then ask the patient to breathe. But before asking breath, you yourself see the abdomen movement. Normal abdominal movement is abdominothoracic. Movement of the respiration, normal abdominal movement is abdominothoracic. Part of the abdomen and thoracic also moves at a time. So, abdominothoracic. The movement of respiration, normally normally there is the inspiration, there is bulging of the abdomen, being reversed in diaphragmatic palsy. If there is diaphragmatic palsy, this in inspiration the abdomen will not bulge. Diaphragmatic palsy. You know what is the nerve supply of diaphragm? Phrenic nerve. Yes, right, very good. So, if there is phrenic nerve palsy, there may be diaphragmatic palsy, and this diaphragmatic palsy can go with the reverse movement. Inspiration, usually inspiration, the diaphragm comes down and the abdomen, you see the abdomen swells, but this diaphragm will not come down and abdomen will not swell. So, this is signs of diaphragmatic palsy. Movement of the respiration resistance and the inspiration being reversed, diaphragmatic palsy. Movement may be diminished as a whole in peritonitis. Very important. If there is underlying infection, peritonitis, there you may see no movement, because patient will, if feeling pain in inspiration, peritonitis, the patient will hold the respiration or move very little. You may not notice it. So it is a reverse movement is in diaphragmatic palsy and less movement is in peritonitis. Now look for any visible peristalsis. You know pyloric stenosis, there is we see the visible peristalsis in the abdomen. Sometimes if you there is a test, if you cannot see it in your bare eye, sometimes we use some irritant in the skin, like give some spirit. Spirit gives a cold sensation, and it reflexly starts the stomach movement, and you can see the visible peristalsis. In pyloric stenosis, there is pyloric obstruction. Hernia, you may not see it, but there is pyloric obstruction. Pyloric obstruction. Then stomach movement, you can see it in the epigastrium. To elicit it, you can give some irritant on the skin just for reflex, to start the reflex movement of the stomach. Usually, you give some spirit like that cold object. Spirit is available, very much available in the world, so it is easily available. Spirit, just spray some spirit over the epigastrium, that you will see the visible peristalsis. So there is the occurs in pyloric obstruction. And colon, similarly, colonic and intestinal obstruction, you can see also some intestinal peristalsis or colonic peristalsis you can see in the abdomen. Then look for any epigastric pulsation. Epigastric pulsations, it indicates normally very thin built person, you can see the epigastric pulsation is here. You have all experienced that. Very thin built person, you just look the abdomen, there is a aorta, with the aorta the abdomen epigastrium is pulsating. You can see it in a very thin built person normally, but abnormally, if it is right ventricular hypertrophy, you can see some pulsation in the epigastrium, and also is the aneurysm of the abdominal aorta. The abdominal aorta, if it get aneurysm, then aortic pulsation may be seen in the epigastrium, and normally in thin built person. Now after that, look for hernias. There are several sites for hernias in the abdomen, you know this. There is a inguinal hernia seen in the inguinal region, umbilical hernia. Umbilical is a site for hernia. Umbilical region, you look for hernia, and paraumbilical region is the paraumbilical, is also called paraumbilical hernia. Incisional, patient has the previous history of operation, suppose gallbladder operation or some appendicular operation. This particularly incisional hernia is very common. Previously, in our days, we saw that if there is a acute peptic ulcer perforation, and the surgeons very quickly have to do the surgeon. Surgeons used to give a lateral incision or a very big incision. Quickly the surgeon have to operate peptic perforations. Nowadays peptic perforations are less because of PPIs, proton pump inhibitors are there. Proton pump inhibitors uses has reduced the peptic perforations, but previously we saw peptic perforations. So these incisions given very hurriedly by the surgeons anywhere in the abdomen, these are the very important sites for this abdominal hernia. But in any hernia, cesarean section, incision site, or any incision may be the site of hernia. That is called incisional hernia, and femoral hernia is of course there. So these are look for hernia or orifices. What are the orifices? These are the orifices in the abdomen from where the hernia may occur. Look for this. Now we are going to our next slide. Now look for superficial veins. Very important. We have already discussed that paraumbilical veins. Why it is increased, why it is distended? Because of portosystemic anastomosis. Normally it is not seen, but when there is portal venous pressure increased and there is increased portosystemic flow, then the veins are distended, we can see it. So, if it is there, then it is very logical to see that the veins are moving, the blood will move away from the umbilicus. No, because the portal vein is there and the system, the portal vein is trying to drain to the superficial veins. So, it will be the filling of the veins will be away from the flow of the veins will be away from the umbilicus. This is clear now as well. This is important because we are coming to this discussion that where you can see the abdominal venous engorgement, not only portal hypertension, we can see it also inferior vena cava obstruction. If there is any inferior vena cava obstruction, so abdominal veins, they all will through the iliac veins or some way they will drain in inferior vena cava. But if they don't get way to drain into the inferior vena cava, what they will do? They will try to drain superior vena cava. Because from superior vena cava they can enter the heart, because their primary motive is to enter into the heart veins. So, if they don't get the pathway to the inferior vena cava, all vein will try to drain to the superior vena cava. There are anastomosis are there, because thoracic the thoracic veins are there, parietal veins are there, where they can drain. Parietal veins, particularly in the lumbar, paralumbar, in the lumbar region, there are thick veins from where they can drain into the superior vena cava. There are ways to drain into the superior vena if there is obstruction in the inferior vena cava. In that case also, the abdomen, you can see engorged veins in the abdomen, but they are mostly seen in the lumbar region, but they can be seen in the abdomen. It may be another cause of, other than portal hypertension, this may be the cause of visible veins in the abdomen, but through conditions are different. One is portal hypertension, what is the inferior vena cava obstruction. So, clinically you will have to detect. So, the pathology is very clear. In portal hypertension, all veins will move away from the umbilicus, be it be above umbilicus, be it be lower umbilicus. If you examine the filling of the veins, you will see that vein is filling, blood is running away from the umbilicus. Above, it is away from the umbilicus towards it, and below, it is away from the umbilicus towards leg. Okay. But in inferior vena cava, the condition will be different. All veins are running above. No veins are running towards the leg. All veins are running toward all veins. They are trying to run above to drain into the superior vena cava. They have no interest to go to the inferior vena cava in femoral veins, because again they will stuck into the inferior vena cava. They will cannot breathe. So, no veins have any interest to drain into the femoral veins. They will all run above. So, what will happen? Above umbilicus, it is away from the umbilicus. But below umbilicus, if you get any vein below umbilicus, that will not away from the umbilicus, that will be towards the umbilicus. If you get an engorged vein in the lumbar region, which is usually you get in inferior vena cava obstruction, in the lumbar region, if you get a vein, the filling will be towards superior vena cava. It is from below upwards, never upwards below. So, make it this concept very clear. So, this is things. So, try to remember this. The portal hypertension, it is away from the umbilicus. In inferior vena cava, above umbilicus, it is away from umbilicus, but below umbilicus is towards umbilicus, because all veins are trying to drain into the superior vena cava. It may it be paraumbilical or may it be lumbar veins, all. So, this inferior vena cava obstruction occur in many conditions. Any hypercoagulable state, what are the hypercoagulable? There are some disease are grouped under hypercoagulable state, like protein C deficiency, proteinase deficiency, factor VIII problem. So, these are the factor VIII related. Hypercoagulable state that can cause inferior vena cava obstruction. But our interest in gastroenterology is Budd-Chiari syndrome. Budd-Chiari syndrome, that is a syndrome, it occurs in inferior vena cava obstruction. There is actually it is a hepatic vein obstruction. Actually, the pathology starts in the hepatic vein. There is hepatic vein obstruction, but as the hepatic vein directly drains into the drains into the inferior vena cava, the clot, that inferior vena, this hepatic venous clot that extends into the inferior vena cava, so obstructs the inferior vena cava also. The pathology starts in the hepatic vein, so of course there is hepatic venous obstruction. But this obstruction extends into the very short veins. Hepatic veins are very short vein and directly draining into the inferior vena cava directly, very short veins. So any venous thrombosis in the inferior vena, in the hepatic veins will extend, invariably will extend into the inferior vena cava. That will cause the inferior vena cava obstruction. That is Barchieri syndrome, and it produces similar features like, and very confusing is that it produces some features very similar to the portal hypertension, but the pathology is totally different. But some similarities are there. So be careful. Either it is portal hypertension or it is inferior vena cava obstruction, because all will cause venous engorgement, all will cause ascites. So similar features are there. So be careful. Reduce this confusion about those things, this slide is very important. How to differentiate a portal hypertension from a inferior vena cava obstruction. Direction of the flow is away from the umbilicus. Here below the umbilicus, it is towards the SBC and towards the umbilicus, that I have already explained to you. Second, ascites precedes edema. In portal hypertension, ascites occurs first, then pedal edema. But in any venous obstruction, edema first, then ascites. Ascites will occur, but edema first, then ascites, because ultimately there will be portal hypertension. But ultimately, inferior vena cava obstruction will also cause hepatic venous pressure rise. This is not portal hypertension, but there is hepatic venous pressure rise, hepatic vein rise, and there will be oozing of blood into the ascites. So both will cause ascites, but here edema is prominent, and edema. But ascitic, this cirrhosis of liver also have patient has edema. You have seen. So edema and ascites in both cases, but here ascites precedes edema. Here edema occurs first, then ascites. The difference. Third difference is spleen is enlarged. Here the spleen is not enlarged, because there is no portal hypertension. There is no splenic vein. You know that portal vein is formed by splenic vein and supramesenteric vein. So if there is portal hypertension, the spleen will be enlarged. The pressure will be transmitted to the splenic vein and spleen. But here it is not the question. No way. Why the splenic vein will get enlarged? Because the problem is in the inferior vena cava. So spleen is not very important. Spleen is not enlarged. Here the spleen is enlarged. Varicosity is present in the paraumbilical veins. You know that this what I have told. It is if the veins are very much engorged, paraumbilical veins in portal hypertension or cirrhosis of liver, if there is very much long-standing portal hypertension and veins are very much engorged, and when there is very much high portal hypertension, this paraumbilical may go varicosed, very much enlarged and varicosed. It is also called Cuvelier-Baumgarten syndrome. It is very difficult to articulate problem, but this is a Cuvelier. You can mention it is a Cuvelier-Baumgarten syndrome. Varicosity is maybe seen in the lower leg veins. Varicosity, because the lower leg veins, they suffer from the much, because they cannot drain properly. There is the most abdominal vein, even they can further from the inferior vena cava, the vein will suffer from draining. So lower leg vein suffers most inferior vena cava obstruction, and they get varicosed. Fifth point, hematemesis from rupture of the esophageal varices or bleeding per annum through the hemorrhoidals are common. That you know that these are the sites for portal systemic anastomosis, and these are the sites for portal bleeding. None of these occurs, because there is a portal hypertension, there is no issue of portal systemic anastomosis and everything. So these things never occurs. Which is upper GI bleeding, lower GI bleeding. These are not the features of inferior vena cava obstructions. Here the portal venous pressure is high, here the inferior vena cava pressure is high. Palpation, then we come to palpation. This ends our inspection. Then come to palpation. What do you do with the palpation? Before palpation, you must keep the patient knee flexed, because it will relax the abdominal muscle. And don't forget to warm up your hands, because in a very cold season, if your hands are very cold and the patient has to lift up the garments, patient's clothing, and just put a hand, এত ঠান্ডা লেগে যাবে যে পেশেন্ট তো প্রথমে রেক্টাস মাসেল কন্ট্যাক্ট করে দেবে, তোমাকে কিছু দেখতেই দেবে না। আর একবার যদি ওই এক্সপিরিয়েন্সটা হয়, তারপরে যতবারই হাত দেবে, ভালো করে হাত দিলেও তখন হবে আমার হবে এবারে ঠান্ডা দিচ্ছে, রেক্টাস মাসেল কন্ট্যাক্ট করে দেবে। রেক্টাস মাসেল একবার যদি মানে অ্যাবডোমিনাল রেক্টাস মাসেল যদি একবার কন্ট্যাক্ট করে দেবে, তুমি কিছু খুঁজে পাবে না। সেই কারণে বি কেয়ারফুল ইন উইন্টার সিজন, you just warm up your hands, and you don't this thing, examiner is also observing you. Examiner is also observing you. In a cold season, if you put a hand, the patient করে উঠলো, করে উঠলো একদম, তাহলে দেখার অভ্যেস নেই, তার মানে he doesn't moving in the ward and the habit to see the patients. হ্যাঁ, এটা হ্যাবিটটা থাকলে তুমি গ্রীষ্মকালেও করবে, হ্যাবিটটা থাকলে। কারণ হ্যাবিটটা এরকম যে শীত, তোমার আর শীত গ্রীষ্ম তখন মনে থাকবে না। ইউ অলওয়েজ ডু দিস। ইফ ইউ মেক ইট আ হ্যাবিট, তখন তুমি আজ দেখবে শীত গ্রীষ্ম নেই, একটু করেই নিচ্ছ, কী আছে, গ্রীষ্মই করলে তো একটু বেশি, হাত তো আর বিরাট কিছু গরম হয়ে যাবে না, তাতে তোমার পেশেন্টের কিছু হবে, পেশেন্টের ওয়ার্ম ফিলিংই হবে, ভালো খারাপ কিছু লাগবে না। বাট ইফ ইউজুয়ালি ইফ ইউ মেক ইট আ হ্যাবিট, তুমি শীত গ্রীষ্ম দেখবে না, করেই নেবে, করে নিয়ে দেখবে। Anyway, the warm up your hands before rubbing with each other in very cold. Start palpation from left iliac fossa. Okay, left iliac from starts palpation from the left iliac fossa. It is the not a mandatory, but it is a norms. Then what we do? Then lumbar. This way you just round up your palpation. Like lumbar, then umbilical, finger. In this way you start. Finger movements must be gentle. একদম পেশেন্ট গিয়ে ঢপ করে টিপে দিলে পেশেন্ট করে উঠলো, সেরকম না। পেশেন্টের টেন্ডারনেস থাকতে পারে, অনেক কিছু থাকতে পারে, তুমি মিস করবে। কাজে ফিঙ্গার মুভমেন্ট মাস্ট বি জেন্টল, ভেরি ইম্পর্টেন্ট। কারণ মুভমেন্ট এক্সামিনার ভীষণ নোট করছে তুমি অ্যাবডোমেন কীভাবে দেখছো। পেশেন্ট শুড নট বি হার্ট। আর যাই হোক, পেশেন্ট যদি একবার হার্ট হয়ে যায়, তাহলে তোমাকে উঠতে দেবে না, তুমি বুঝতে পারবে না। তাই তাহলে মাস্ট বি জেন্টল অ্যান্ড ফ্রম মেটাটার্সোফ্যালেঞ্জিয়াল জয়েন্ট, দিস তোমার পেশেন্টের হাত দেবে, তোমার হাত উঠবে, এইখানে বেশি চাপ পড়বে না, তোমার হাতটা উঠবে, তারপর চাপ দেবে, আগে হাতটা উঠে যাবে এইখানে, তারপর চাপ দেবে। এই মুভমেন্টগুলো এক্সামিনাররা দেখে, একটু খেয়াল করে করবে। এক্সামিনার মুভমেন্ট জয়েন্টস, আর তুমি এইভাবে করতে শুরু করলে, এইভাবে করতে শুরু করলে, ইট ইজ নট দ্য ওয়ে। এইভাবে করলে তারপর মেটাটার্সোফ্যালেঞ্জিয়াল জয়েন্ট চলবে। এবার তোমার মুভমেন্টটা এইভাবে হবে, এইভাবে নয়, নট লাইক দিস, এইভাবে এই করে তারপরে মেটাটার্সোফ্যালেঞ্জিয়াল, এইভাবে মুভমেন্টটা করো। আমরা যখন পেশেন্ট দেখবো তখন we'll go details into it. Finger movement must be gentle and from the metatarsophalangeal, superficial. Then now we do the palpations. We do the palpations in superficial palpation and deep palpation. Superficial palpation, what we see, the consistency. Normally the abdomen is feel elastic, but there are terms. There are several terms. You should be acquainted with these terms. Like, what is rigidity? Rigidity means there is hard feeling. You are feeling hard. Abdomen feels hard. You cannot penetrate your hand. You cannot push your hand. It occurs in peritonitis, abdominal rigidity. Or it may be doughy feeling. Doughy. The term is important. Doughy feeling, it is often tubercular peritonitis. Doughy feeling is a particular feel that you can, if you have an experience, you can feel it. Doughy feeling. It is like that. তুমি মানে একতাল ময়দার উপরে হাত রাখছো, ঠাসা ময়দার উপরে হাত রাখছো, this is called doughy feeling. This doughy feeling occurs in tubercular peritonitis. And guarding over an infected organ, muscle guard. When there is generalized, we call this rigidity. When there is, there is appendicitis, you have seen that if you put a hand over the appendicitis, there is a muscle guard. We called it a muscle guard, not rigidity. Rigidity is a term when the whole abdomen is involved. And the localized organ appendicitis, If you push there, there is a muscle guard, called appendicitis. Similar guard may be found in acute cholecystitis also, over the organ. You feel some guard. Then after that, go look for any tenderness. Indicate an inflammation. Tenderness should be described in the region way. Which region? Umbilical region, hypogastric, right hypochondriac, left hypochondriac. If there is tenderness, you mention the region of the tenderness. It is the right hypochondriac is tender. There is tenderness in the right hypochondriac. This is the way. Or there is a tenderness in the hypogastrium. This is the way you describe it. If there is tenderness, then diffuse, then indicates inflammation. Diffuse or point diffuse, will be diffuse tenderness. যেখানে অ্যাবডোমেনে যেখানে দিয়ে হাত দিচ্ছ সেখানেই ব্যথা, পেরিটোনাইটিস হবে। ডিফিউজ টেন্ডারনেস, তুমি যেখানে হাত দাও সেখানেই ব্যথা, পেরিটোনাইটিস হয়েছে। or it may be localized if there is organ involved. Then look for any localized lump. Superficial, when you are abdomen, superficially you are not pressing the abdomen, you just at a হাত বোলাচ্ছ abdomen over, superficial. Some information to be taken when you are in superficial palpations. So a lump may be abdomen, হাত বল পেটে হাত বোলা দিয়ে তুমি দেখলে একটা লাম্প তোমার পেটে লাগলো, হাতে লাগলো, কোনো ডিপ প্যালপেশন এখনো যাওনি, জাস্ট সুপারফিশিয়াল প্যালপেশন, এ লাম্প মে বি felt in your hand, in your palm. There is a localized lump. When there is a localized lump, always do a rising test. Rising test means patient is in a lying down position, ask the patient to sit up. If there is a parietal mass, if the mass is in the parietum, in the skin, below the skin and in the rectus muscle, not inside the abdominal cavity, then that mass will be prominent, more prominent, because it will prominent, the muscle, rectus muscle will contract and the parietal mass will be more visible when the patient sits up, and the opposite things occurs in the intra-abdominal mass. If the patient tries to sit up, the intra-abdominal mass will be less visible. So this is a sit-up test you should do if there is, you feel a lump there. Of course, the patient, if the patient is very sick, you cannot do that. Don't ask a very sick patient to sit up. If the patient cannot, if you cannot patient do that, don't ask him to do. It's just tell the examiner the patient is too sick to do this test. Yes. Localized lump, partial more prominent intra-abdominal mass swelling disappears. Fluid thrill, important fluid thrill, you know that you know all these fluid thrills, that fluid thrill, it requires at least 1.5 to 2 liters to make the fluid thrill positive. And don't forget to put a hand of the patient. Patienটের হ্যান্ডের একটা আলনার সাইডটাকে মাঝখানে রাখতে হবে, তা নাহলে তোমার এমনি এখানে টোকা দিলে স্কিন দিয়ে তোমার হাতে, এই তোমার অপরিচিত হাতে ট্রান্সমিটেড হয়ে যেতে পারে। সেটাকে আটকানোর জন্য পেশেন্টের একটা হাত এখানে রাখতে হবে, এখানে রাখবে আলনার বর্ডারে, ঠিক আছে, তারপর তুমি একদিকে ট্যাপ করলে আরেকদিকে ফিল করলে, দ্যাট ইজ ফ্লুইড থ্রিল। বাট ভেরি ইম্পর্টেন্ট যে ইফ দ্য ফ্লুইড থ্রিল ইজ পজিটিভ means there is a huge ascites, at least 1.5 to 2 liters fluid to be there to make this test positive. Maybe falsely positive in obesity, just false positive, maybe obesity, even in ovarian cyst also. It is not a hard ominous sign for fluid in the abdomen. Ascites, it is not a ominous sign for ascites. Ascites means it is a free fluid, it is not encysted, free fluid. It is not a ominous sign for free fluid, that does not indicate there is free fluid, it indicates there is fluid. Ovarian cyst or encysted, it may be as it is in paralytic ileus. In paralytic ileus also, ileum may be hugely enlarged, there may be fluid, you may get a fluid thrill. So it is not a sign, you cannot tell the fluid thrill is present and the patient has the ascites. No, you cannot tell. This is not free fluid. Maybe encysted fluid in the intestine or maybe ovary. And look for diversion. It's very important. Very commonly we see there is diverification of the recti. The recti muscles are, often you have seen in patients. Normally patients see the mass, the middle there is a gap. There is diverification of the recti. This is a common finding normally in some patient. Just if it is there, look for it. Now palpation continued, direction of the blood flow. Now we have seen the engorged veins. Now you will go for direction of the blood flow test in palpation, because now you are palpating, you are now touching the patient. So palpation, so you see the flow, and flow, how to see? If there is a veins like this, just choose a vein. It is written there, choose a vein which is not tributaries, because if you just empty the vein, if the vein has a tributary, that will feed the vein. So just look for some time to choose a vein. Very important to choose a vein. Which vein I will show, or which vein I will see. That vein should be straight, preferably at the below the umbilicus. Why? Because above umbilicus you cannot differentiate, but below umbilicus you can differentiate. That is inferior vena cava or portal hypertension. So preferably below umbilicus. If I get it, what will be my choice? My choice will be a straight vein without tributary below umbilicus. That is the ideal vein. It will differentiate portal hypertension. ফ্লোটা কীভাবে দেখতে হয় না, আমরা যখন পেশেন্ট পাবো, যদি পরে দেখবো, এইভাবে চেপে একটা থেকে করে দিলে নিচের আঙুলটাকে বাদ দিয়ে উঠিয়ে দিলে, যদি ওপরে করো তাহলে ওপরের আঙুলটা ওঠাবে, তাহলে দেখা যায় ফট করে ভেনটা ফিল করে গেল, তার মানে ওপর দিকে ব্লাড যাচ্ছে। ঠিক আছে, এটা তুমি জাস্ট কলের একটা ছাদে পাইপ দিয়ে জল দেয়, এরকম চিন্তা করো, জল যাচ্ছে, এবার তুমি চেপে দিলে জোরে আঙুল দিয়ে, তো জলটা যেদিকে যাচ্ছে সেটা বোঝা তো খুব একটা কি এক্সপেরিয়েন্স ব্যাপার না। একটা আঙুল তুললেই তো বুঝতে পারবে কোন দিকে জল যাচ্ছে, বাঁ দিক থেকে ডান দিকে না ডান দিক থেকে বাঁ দিকে, তাই না? ওখানে দেখতে হবে না কল থেকে জল যাচ্ছে, ওখানে পড়ছে, তো মাঝখানে যেহেতু আমার বসানো হয়, বুঝতে পারবে না কোন দিকে জল যাচ্ছে, দুটো আঙুল দিয়ে চেপে দেবে, এদিকে তুললে এদিকে যাচ্ছে, আর যদি তুললে তাহলে এদিকে যাচ্ছে। তো সিমিলারলি ইন ভেন, তুমি দুটো আঙুল দিয়ে এরকমভাবে চাপবে, এবার একটা আঙুল তুলে দেবে, যদি এদিকে ফিল হয়ে যায় তাহলে এদিকে যাচ্ছে, এইভাবে ডাইরেকশন অফ ফ্লোটা দেখতে হবে। এনিওয়ে, তা যখন যদি পেশেন্ট পাই আমরা আরও ভালো দেখতে পাবো। ঠিক আছে, তাহলে প্রমিনেন্ট অ্যাবডোমিনাল ভেন্স উইদাউট ট্রিবিউটারিজ আমরা দেখবো ইন ইজ চোজেন দ্য সিট আপ অ্যান্ড দিস। একটা জিনিস, যে পেশেন্ট যদি ভালো থাকে, বেশ শক্তিশালী আছে সব কিছু, তাহলে তাকে সিট আপ অ্যান্ড কাফিং করলে ভালো হয়। সিট আপ কাফিং করে দিলে, যদি পাটা ঝুলিয়ে দাও বেড সাইডে পাটা ঝুলিয়ে বসিয়ে কাশালে সবচেয়ে ভালো ভেন প্রমিনেন্ট হয়। তো পেশেন্ট করতে পারলে করবে, নাহলে যেরকম আছে এরকমই দেখিয়ে দেবে। র্যাপিডিটি অফ ফিলিং dictates the direction of flow, যেটা আমি বলেছি তোমাদের। এবার ডিপ, নাও superficial palpation ends, now we go for deep palpation. Now I am pressing my palm to see the deeper structures. এখানে patient breathes quietly, head turned to the left side, you are standing on the right side of the patient and the patient head is turned to the left side. During palpation of the liver, spleen and kidneys, patient is asked to take deep breath, because these are the organs moving with the respiration. Kidney doesn't move much with the respiration, but to differentiate it from spleen. Now spleen mass, splenic mass will move with the respiration, but kidney mass will not move with the respiration. So just take a patient asked to take a breath, the liver will move with the respiration, spleen will move with the respiration, kidney will not much with the respiration, because it is not. So this is for patient, ask the patient to take deep breath and see whether this mass is moving. If the mass is, in any case, in any mass anywhere in the body, if you get a mass, you have to describe the mass in these points, following points. It is not only for abdomen, anywhere if you get a mass to be described. Suppose you get a mass in the neck, okay, mass in the neck, describe the mass in this way. These points, all points to be covered when you describe a mass. What are the points? What is the site? It is in the neck, or it is in the hypogastrium, or the site means the 9 regions. Which site is a site? Size in centimeter. You'll have to give the length and breadth. Say it is 4 centimeter by 3 centimeter. Means it is a 4 centimeter in length and 3 centimeter in breadth. 4 by centimeter by 3 centimeter lump in the right hypochondrium. Suppose I am telling you this like this. So size and shape of the lump. Shape of the lump is important. It may be a globular lump, it may be a flat square lump, it may be triangular lump, like that. But the shape of the lump is important. It is circular. Most of the lumps are circular in shape. Consistency. What is the lump is consistency? How it is consistent? It is like stone, it is like rubber, or it is very soft, like very soft. So this is the consistency of the margin. So, but if it is hard, you have to mention this is a hard. But hard mass always goes in favor of carcinoma and others. So anyway, so you have to the consistency is very important. Then then you describe the margin of the lump. Whether the margins, if you palpate the margin, whether it is a regular margin or it is irregular, means it is a regular margin or maybe irregular margin, like that. So describe the margin is very important because irregular margin goes in favor of carcinoma. Like this is not always, but you should describe every mass in this way margin. Then you describe the surface of the lump. It is a irregular surface or regular surface of the lump, regular or irregular surface. Then movement with respiration. This mass is moving with the respiration or not. A hepatic lump will move with respiration. Splenic lump will move with respiration. Okay, so like that, the moving with respiration or not. Is this pulsatile or not? Very important. If you get an aortic aneurysm, it may be a huge aortic aneurysm. You can get epigastric lump. You just then you describe the lump. It will definitely it will be very soft. Margins will be regular, and this is a site, and it will be pulsatile because the aortic lump will be pulsatile, and because this is aorta, or even a very vascular tumor may be pulsatile. Very vascular tumor may be pulsatile. Sometimes the liver also may have a very vascular tumor. Anyway, so this is pulsatile or not? That is important. Palatable or not? Palatability, you know what is palatable? Put a hand above the lump and below the lump. Push it from way above. See whether the lump is thrusting in your front hand. Or similarly, do the reverse. Push the lump from above and see whether it is touching in your, it is thrusting in your below hand. This is palatable. This palatability is positive in renal lump, but palatability is not positive in splenic lump. Okay, is important. So there is a lump in the left lumbar region. It may be splenic, maybe left lumbar region. It may be splenic, maybe kidney. When then these issues will come, which is renal lump or splenic lump. Renal lump will be palatable, splenic lump will not palatable. Okay, we'll have to finish this class today. Then spleen, if the mass, we describe this mass in this way. Then it is whether there is a mass is tender or not. Very important, whether it is tender or not. All points to be discussed. All points to be discussed. You'll have to mention in regarding a lump. Then condition of the overlying skin. Overlying skin, how it is there. You have to mention. This is, how is the overlying skin? Fixity with the underlying structure. The mass is moving with the underlying structure or not. If it is fixed, the underlying structure, it indicates the mass is a malignant mass. It is fixed to the underlying structure. So moving to that, all these points to be discussed in a, if you want to describe a mass anywhere in the mass, you describe in these points. Then rebound tenderness, we found it. Peritonitis, we found a rebound tenderness. That is when you lift your hand, the tenderness comes. When you press, it does not occur. Suddenly you left, the patient tenderness. When you leave the hand, suddenly, so it is called rebound tenderness. Not at the time of pressing, but at the time of releasing, the patient has pain. It is called rebound tenderness. And it is also called Ropsing sign. It is found in it is also rebound tenderness, and this Ropsing sign and appendicitis is different. Ropsing sign is appendicitis. Appendicitis, you know, it is on the right sided iliac fossa structure. If tenderness should be on the right side. But sometimes if you press it or press the left side, the colon will touch the appendix is very much tender. This is the distended colon will touch the appendix and it will cause pain in the right side. So pressing the left side of the iliac fossa, patient is feeling pain on the right side. It is called Ropsing sign. It occurs in appendicitis because the appendicitis is in the right side. Then you got percussion. General percussions with normal note is tympanic note. Normal note of the normal percussion note of the abdomen is tympanic. Okay. Same thing, resonant and resonant over organ. The term resonant and over the organ it is resonant, but if it is over the gas intestine it is tympanic. This percussion in the chest, these terms are used as resonant, hyperresonant or dull. These three terms are used in chest. There is a tympanic term used in chest. It is resonant, hyperresonant or tympanic, resonant, hyperresonant or dull. But in abdomen, there is a special word called tympanic because you are percussing over gas filled structure. This is called tympanic, but it may be resonant like your normal lung if you percuss it over the organ. Now, normally the start percussing, then organ. Upper border of the liver dullness is very important. Start percussing from the right second intercostal space. Upper border liver dullness is very important to detect. How to detect? So start percussing from the right second intercostal space, then go on percussing till the dullness is found. Normally, upper border of the liver dullness is at the level of the fifth rib, 2 centimeter medial to the right midclavicular line. This is the normal area for liver dullness, normal liver. And upper border of the right lobe of the 8th rib in midclavicular line, it is the left lobe of the liver, right midclavicular line. Now, important is trough space. What is trough space? I have given the boundaries of the trough space. Above it is left 6th rib, inferior it is left costal margin, lateral it is left anterior axillary line, and medial it is left sternal border. This is a triangular semilunar space at the lower end of the chest. Trough space is important because if there is confusion, mild splenomegaly is there or not. Confusion. কেউ বলছে হ্যাঁ স্প্লিন আমি পাচ্ছি, বলে না আমি তো পাচ্ছি না, then go for trough space because it's a very early sign for splenomegaly, the trough space percussion. যখন কনফিউশন হচ্ছে, বলছে আমি পাচ্ছি, বলে পাচ্ছি না, হতেই পারে স্প্লিন নিয়ে প্রায় গন্ডগোল লেগে যায়। আমি বলে পাচ্ছি ছোটো স্প্লিন আছে, বলে না নেই, আমি পাচ্ছি। Then go for trough space percussion because it's a very sensitive clinical method for detecting splenomegaly. The trough space. This is the area for trough space. It is crescent shaped state. I have already discussed. Normally, it is tympanic because the normal content of the trough space is fundus of the stomach. So, gas in the fundus, we get a tympanic sound. But if it is dull percussion, dull in percussion, possibility of splenomegaly, or if there is left-sided pleural effusion sometimes. Left-sided pleural effusion, sometimes it may becomes dull. Then shifting dullness. Oh, you all know shifting dullness, very much discussed, very much favorite subject to discuss for the examiner. Shifting dullness is a fluid thrill together with a single make it the dangerous is the diagnosis. This shifting dullness is the surest sign for free fluid. It is a surest sign for free fluid. If I in next hour, if I get a patient, will demonstrate how to show the shifting dullness. Then its method is very important. We will show it in the bedside. It is not possible to discuss here. Only bedside you can see, we can demonstrate how to see the shifting dullness. But absence of both does not exclude ascites. So definitely, if the presence of shifting dullness is surest sign for ascites or free fluid in the abdomen. Fluid more than 500 ml is positive. So, in fluid chill, we have told it is at least 1.5 liter fluid is necessary for fluid chill. But here, even as low as 500 ml fluid can give you the positive shifting dullness. Positive. But another sensitivity is the USG abdomen. Ultrasonography abdomen. But if you ask them what is the most sensitive, it is ultrasonography. Definitely, ultrasonography will detect as low as 100 ml of fluid. That's important. The ultrasonography 100, shifting dullness 500, fluid chill 1.5 liter. Simple. So, common causes of ascites are there. You know all this, still I have for recapitulation, there are the hepatic causes we have already discussed, portal hypertension, CA liver, hepatic vein thrombosis or Budd-Chiari syndrome, I have already discussed. Cardiac causes are congestive cardiac failure and constrictive pericarditis. These are the causes of ascites. Like inflammatory obstruction, in constrictive pericarditis or congestive cardiac failure also, edema will be first occur, then ascites. But in cirrhosis of liver, ascites first, edema second. Renal nephrotic syndrome, there is any conditions causing low albumin will cause ascites, because the albumin low will get ascites, but the basic pathology is low albumin. Nutritional cause malabsorption syndrome, all causes albumin, low albumin, and hematological causes lymphomas and chronic myeloid leukemias. That can lymphoma is an important differential diagnosis for ascites. This is actually it is a malignant ascites. Lymphatic ascites like thoracic duct obstruction can cause thoracic duct obstruction can cause this is a lymphatic channel. Thoracic duct obstruction or filaria is called lymphatic. The chylous fluid may accumulate in the abdominal cavity. There may be ascites and infections like tubercular peritonitis and of course malignancy. Malignant peritonitis is malignant deposit in the abdomen called malignant peritonitis. So these are the important causes of ascites: cirrhosis of liver, tuberculosis, malignancy, lymphoma. These 4 causes, don't forget, just utter in a breath. What are the causes of ascites? In a one breath, utter these 4 terms: cirrhosis of liver, tuberculosis, lymphoma and malignancy. Of course, then ask for malnutrition. If there is hypoalbuminemia due to any cause, nephrotic syndrome, congestive cardiac failure. And nephrotic syndrome, there is albumin low, edema আগে হবে, সব কন্ডিশন যেখানে অ্যালবুমিন এখানে তোমার এখানে একটা ব্যাপার আছে। ব্যাপার হচ্ছে তোমার এখানে সিরোসিস অফ লিভার লো অ্যালবুমিনের জন্যই হচ্ছে, কিন্তু লো অ্যালবুমিনের সাথে যোগ হচ্ছে পোর্টাল হাইপারটেনশন। দ্যাটস ওয়াই দ্য ascites gets ফার্স্ট ইন সিরোসিস অফ লিভার, because in cirrhosis of liver there is low albumin is the principal cause, but portal hypertension also add to it. That's why ascites occurs first. লিভার টুতে উজিং হচ্ছে, পোর্টাল হাইপারটেনশন একটা তো হাইপোঅ্যালবুমিনের যেটা হচ্ছে the portal hypertension এক্সট্রা লিভার থেকে উজ করে কিছু ফ্লুইড পড়ে যাচ্ছে, সেই উজিং ফ্লুইডটা এক্সট্রা জয়েনের চুলোটা আগে হয়ে যাচ্ছে। এনিওয়ে দেখো, তাহলে এটা গেল তোর ইনফেকশন টিউবারকুলার পেরিটোনিটাইটিস। Next, our cover, then we go for auscultation. Auscultation, you know the stethoscope, this chest piece of the stethoscope preferably be placed on the right of the umbilicus. At auscultation, আমি কোথায় করব? First শুরু করব right side of the umbilicus দিয়ে, because that is a place where the abdomen can be auscultated. A window is better window to get. This is a right side. This is a convention just. So what are the auscultatory findings may be there? Just there is maybe intestinal peristaltic sound. We call it rapid IPS. IPS is hurried. Or IPS, intestinal peristaltic sound is hurried. Occurs in intestinal obstruction. Succussion splash in pylori stenosis and pyloric ileus. Succussion splash is in pylori stenosis. There is a fluid in the stomach. You put a stethoscope in the front of the chest and just shake the patient here like this. We will get a water is moving in the stomach, because stomach is distended. In pylori stenosis there is distended stomach and water is there, and you will just shake the patient. Similar succussion splash is also you do it in a chest case in a hydropneumothorax. If there is hydropneumothorax, sometimes you shake the patient and put a chest, you get a awaj of this sound of this moving water in the ear. In the space the water is moving like that. It's called, what here it is called succussion splash. The term is used for abdomen pylori stenosis and pyloric ileus. Friction rubs over the liver and spleen. The friction rubs, there is a corporate sound. There is a sound. Friction rub is not just শুকনো পাতা হাত দিয়ে মোড়ালে যেরকম সাউন্ড হয়, মরমর একটা সাউন্ড, ওরকম একটা সাউন্ড কানে শুনতে পাচ্ছি। That is friction rub. It occurs in over the infection or in the organ infection. If the patient is a infection organs increased with respiration, naturally the splenic rub or the hepatic rub or splenic rub, it will increase with inspiration. There will be more friction. There will be more friction. There will be more sound. It occurs in perihepatitis and perisplenitis. Following liver biopsy, it is also common. Following liver biopsy, there is a infection in the surface, and we got a hepatic rub, or following splenic infarct over the spleen, there will be splenic rub. Renal artery stenosis, renal artery stenosis is the renal artery gets stenosed. We get a systolic murmur in the lumbar region over the renal artery. We get a systolic murmur. Look for it. If it is there, it is renal artery stenosis. It causes secondary hypertension. Renal artery stenosis. Venous harm over dilated parambilical vein, it is called cirrhosis of liver, also called Crubel-Baumgarten syndrome. We have called it is a tortuous veins, varicose veins. It is called the caput medusae is there. In that, if you get a sound like that, then you call it a Crubel-Baumgarten syndrome. You get a harm in the Crubel-Baumgarten syndrome. I have already mentioned. Here you get a venous hum. It is called venous hum. It is a continuous sound. Huh? How about the vein veins, lateral veins? Because there is increased movement, na? Pedal vein is draining into the vein and there is increased movement. So, there is a systolic murmur over the veins. It is called hum, venous hum. Okay. It is not called murmur, it is called hum, HUM. But it is hears like a murmur. Then pansystolic murmur over the epigastrium increases with inspiration, may be heard in the epigastrium in the tricuspid stenosis murmur. The heart is very much enlarged and the tricuspid area is very much close to epigastrium, very much close to epigastrium. That murmur you can listen it in the epigastrium, you can get the murmur of tricuspid stenosis. It is called Carvalho's sign. Just is the names you can, if you can remember, just remember. It is called Carvalho's sign. When the murmur is seen in the epigastrium, this tricuspid murmur, it is called Carvalho's sign. Now we end our discussion. Next day, either we will go for discuss the liver and liver diseases. But if I get suitable case, we will go to the bedside. If I don't get suitable case for bedside discussion, we will discuss different diseases of the liver. We will start with the different diseases of the liver, or we will go to the bedside. Next class, okay? Thank you. Sure.